Good evening, everyone, and welcome to Precision Treatment, Understanding Proton Therapy. My name is Savina Chacheva, and I'm the Program Director at the Cancer Wellness Center, and I will be moderating this evening's lecture. Before we get started with the lecture, I would like to share more about the Cancer Wellness Center and our programs and services. The center was founded in 1989 as a nonprofit organization with the mission to help anyone touched by cancer find a way forward. Each year, our free counseling services, support groups, health and nutrition programs serve over 2,000 community members of all ages and backgrounds. People with cancer, family members, friends, and caregivers all come to us to connect and cope. Our services, which are both virtual and in person, include education programs like the one this evening that aim to help you navigate the varied challenges that come with living with a cancer diagnosis. Wellness classes like yoga, meditation, nutrition, exercise, acupuncture, and more that provide a holistic approach to healthy living. And support services including counseling for individuals, families, couples, children, and those bereaved, as well as support groups that are designed to help our participants manage the mental and emotional impact of cancer. If you would like to learn more about the center and connect to our free programs and services, please visit cancerwellness.org, and I will include the link in the chat shortly. Now I would like to thank you and welcome our presenter this evening, Dr. Neal Andruska. Welcome.
All right. Hi, my name is Neal Andruska. I'm a radiation oncologist at Northwestern. I work predominantly at our Proton Center. It's the only Proton Center in the Chicagoland area, and it's located in Warrenville, Illinois. So I will be discussing proton therapy and some of the unique applications of protons that we frequently use and talk about some of the pros and cons of proton therapy. So I'm going to share my screen here.
Perfect.
Okay, great. All right, whoops. Okay, so title of the talk is Precision Treatment, Understanding Proton Therapy. Again, I'm Neal Andruska, and I work at Northwestern. Whoops, frozen here. Okay, so for starters, what's the difference between proton therapy and traditional radiation, which is known as photon radiation? I know those words are very close to one another, but again, I'll just repeat. Photon radiation with an H relates to traditional radiation treatment, and proton radiation with an R relates to a specialized type of radiation treatment that we sometimes give in certain clinical scenarios. So this slide basically depicts the differences between proton and photon radiation. For starters, photon or traditional radiation is the most common type of radiation treatment given. Roughly about 2/3 of cancer patients during some part of their cancer journey end up ultimately getting radiation treatment. So it's fairly common to have to need radiation at some point during that journey, whether it's upfront in a more curative, definitive intent setting, or later down the road to palliate symptoms, for example. So with traditional radiation, which is the most common type, it's basically a packet of particles that are directed at a patient, and the intended target, let's say in the center of the patient, is where those photons are directed. However, some of those photons will hit the target, but there'll be some that go beyond that point in space. So with photon radiation, they give off the greatest dose near the surface of the skin, and then the dose starts to fall off dramatically. With proton radiation, in contrast, this is more of an advanced form of radiation therapy that's been around actually for many, many decades, but really put into therapeutic use in the last couple decades where really we see a big increase in the commercialization of this type of technology. Um, with protons, the major contrasting difference is that that same target in the center of a patient, we're able to direct protons at that target, and there's really no radiation dose that goes beyond that point in space. So in contrast to photons, where the greatest dose is near the surface of the skin, in the case of protons, it gives the greatest dose just before the beam ends at the site of the tumor or the target. So I know this is kind of complicated, but another way to explain this, and this may be a little bit easier, again, contrasting photons and protons, is that the major difference is that photons have an exit dose, which leads to radiation going beyond the intended target. And so that's really depicted here. This green line would be a photon beam. And you can see that the intended target is this area right here, denoted by this vertical gray line. And you see that there's radiation that goes beyond that point. So low dose and intermediate dose radiation that goes beyond that point of the tumor or the intended target. With protons, because we're now dealing with positively charged particles, we have a lot more control over where these particles end up going because of the fact that they are charged. It's called a Bragg peak, but basically the gist of it is that when we target that same area again, that you don't have any dose that goes beyond that point. So we can change the energy of the proton beam, and in doing so, we can change at which, the depth at which that proton beam goes. So on the left side, if we use a less energetic proton beam, you can see that the proton beam will deposit its energy more shallow in the patient. Similarly, if we make the energy of the beam even more energetic, then we will end up depositing dose deeper in the patient. So by changing the energy of the beam, we can change the depth at which that radiation goes to. Similarly, we can put the charged particles in a magnetic field, and that allows us actually to steer the radiation beam back and forth by changing the magnetic field. So the analogy I always use is it's kind of like painting a fence where we are able to essentially paint radiation dose into a given target. And there's really no radiation dose that goes beyond that point. So as an illustrative example here, if you have a tumor that's kind of wrapping around the spinal cord, and we want to avoid giving radiation dose to the spinal cord here, we can essentially send a beam in and basically change the magnetic field and steer the beam back and forth. And by changing the energy of the beam, we can essentially change the depth at which that radiation goes to. And again, kind of like painting dose into the target, you can see here that we're able to kind of paint radiation dose in to the target that wraps around the spinal cord and really minimize any radiation dose that goes to the intended target. So this has a couple important implications. One, it allows us to minimize toxicity with proton treatment. And two, because of the fact that we're able to spare normal structures, we're able to, in some cases, be more aggressive with how we treat the cancer by escalating the dose, because we have the ability to increase the dose without the detrimental effects on the normal structures that are adjacent to what we're trying to target, in this case, a tumor. So proton centers, like I mentioned a few minutes ago, they have been around really since the 1960s, 1950s, I actually believe. And really until the 1990s, that's when we saw more of the commercialization of these centers. Our proton center has been around since, I believe around 2010, if I recall correctly. But there used to be, a select number, 10 or 15 proton centers. And since then, the number of proton centers has continued to increase. You can see on this map here all the proton centers around the country. You can see there's a big concentration of them in the East Coast as well as in Florida. And obviously, the major cancer centers across the country have these proton centers. That includes University of Pennsylvania, Memorial Sloan Kettering, Mass General or Harvard, MD Anderson, University of California, San Francisco, and other centers. There's a number that are actually under construction. If you notice, there's not a lot of them in the Midwest. There was actually a Proton Center recently opened in Peoria. It's a single room treatment center that just was brought online in the past year. They're also working on building one in Milwaukee right now, associated with MCW. And then I guess competing with MCW, there's one that is being built at University of Wisconsin-Madison right now. But there's not a lot really in Illinois. There's, like I said, the one in Peoria, but other than that, it's really Mayo Clinic or it's WashU in St. Louis are the closest centers. So ours again is in Warrenville, and the way it works is we actually have, shown in this top right photo here, we have 4 treatment rooms. The protons themselves are generated in this apparatus called a cyclotron. And when these protons are created, they're sped up to very high speeds, and then they're funneled down this track, this beam line, and then funneled into each of these rooms. And each of these rooms do unique things. We have different types of beams in different rooms. So, for example, we have horizontal beams, we have inverted beams in a few of our rooms. And then we also have, in one of our rooms, something called a gantry machine, which is actually a 2 to 3 story machine. You can't actually see it in the room, but it's actually suspended a few stories up. But it's a giant machine that basically rotates around the patient, and it really gives us 360 degrees of freedom so that we can really treat a patient from any angle. So we have various different machines that we use for different clinical applications. But this is really the nuts and bolts of the Northwestern Proton Center. So what do we use protons for? What are the indications? And as I mentioned before, traditional radiation is an excellent option, but there's certain times where we really rely on protons. And here's a few examples of these. Some of these are more clear cut. Others are scenarios where there's a perceived benefit of protons, but photon-based radiation is also going to lead to a very good outcome as well. So the biggest indication is really that the target volume or the tumor is near one or more critical structures, and you really need to have a very rapid dose fall off to avoid exceeding the tolerance dose to these critical structures. So these are just a few examples here, but on the left side, there's something called a clival chordoma, and that chordoma is actually pushing on the brainstem, and the brainstem is right here. The challenge with these types of tumors, which are in the sarcoma family, is that we need to give a really, really, really high dose of radiation to these chordomas or these chondrosarcomas. And that dose is much, much higher than we can give to this brainstem right here. And so in these cases, we essentially have to treat with protons. We don't really have any other option because there's really no way to effectively treat the tumor and kill the tumor without overdosing the normal structures, in this case, the brainstem. The brainstem is kind of like the highway system for your brain. All of your major neural networks that control all of your motor and sensory function run through there. A lot of other really important functions are located in those centers, including the respiratory center and the centers that control your heart rate, for example. So this is a very important area and definitely an area that you don't want to damage. And so most of the patients in the Chicagoland area, really in the Midwest and actually regionally, as far as Canada, for example, will come to our Proton Center for treatment of these types of tumors, because really with traditional radiation, you cannot treat these tumors. Another example here is something called a uveal or choroidal melanoma. It's where you basically get melanoma in the back of your eye. This is another illustrative example where the optic nerve is really behind here, as well as the regular brain. And we need to send a really high dose to this tumor to kill it. But we don't want to send such a high dose that it would potentially damage the optic nerve. Because we're able to basically stop the protons exactly where we want them to stop, and there's not radiation that goes beyond that point in space, we really rely heavily and really exclusively on protons to treat these types of tumors called uveal melanomas. The last one is a little bit more subjective. but it's an illustrative example, and I'm going to come back to this in a lot more detail later. But this is a patient with breast cancer, left-sided breast cancer, and you can see here that their heart is actually right behind the chest wall. And in these types of scenarios, and again, I'm going to explain this in more detail later, we can achieve better or really less radiation dose to the heart and to the blood supply for the heart by using proton radiation in select cases of breast cancer. So I'll come back to that in more detail in a minute. But the other indications for protons really fall into another basket. And that basket is really where proton-based techniques decrease the probability of clinically meaningful toxicity by really lowering the overall integral dose to the surrounding structures. And so when we use the word integral dose, we're really talking about scatter or radiation dose that goes to other areas of the body. And these are some illustrative examples where we typically use protons. There's something called cranial spinal irradiation. We sometimes will do this in our pediatric patients where we're worried about their brain tumors, for example, having extension into the spinal canal. We also use it in adult populations of patients for solid tumors that unfortunately develop something called leptomeningeal disease. And in all of these scenarios, the gist of it is that we radiate the brain as well as the entire spinal axis, because the goal is to basically irradiate all the tissue that could potentially have cancer involvement. You can see here that with photon-based radiation, the red kind of denotes the highest radiation dose, but you see all this blue and green and yellow dose with the photon, the traditional radiation. And so the gist of it here is that when we give radiation to the brain and to the spine, we are basically radiating the palate, the back of the mouth, the oropharynx, and then all the way down the airway and into the lungs. The lungs are getting radiation, the heart, and the entire abdominal cavity. And so this is very, very toxic, especially in adults. But you can see here that with something called IMPT, which is the most recent generation of protons, you can see that we basically are able to, again, radiate this entire axis, but there's not a lot of radiation dose that spills into the adjacent compartments and thereby reduces the amount of toxicity. Now, in children, this is particularly important because in young kids, we do know that the more scatter dose, the more low dose radiation, and this also is illustrated for adults too, but especially in children, we know that when we minimize this dose, we minimize their risk of developing secondary cancers later in life. And this could be in the form of thyroid cancers, hematological malignancies, other cancers that could form 20 years after the initial radiation course. So this is can be particularly important when we use protons for cranial spinal radiation and minimizing toxicity. Another great example is something called a low-grade glioma. It's a brain tumor. In this case, they're lower-grade gliomas, and we often would recommend using protons in these scenarios. These are often patients that are either pediatric or they're very young, for example, in their 30s or 40s that develop these tumors. And so you can see on the left, this is traditional radiation versus on the right, which is proton radiation. And you can see that we basically are able to spare the overwhelming majority of the brain from any sort of radiation dose when we use protons. And the brain, is high-priced real estate. It's kind of like living in Lower Manhattan. Everything in the brain is important. We want to try to really minimize any radiation dose and minimize any sort of neurocognitive potential changes that could occur by using protons and really minimizing radiation dose. And lastly, at the bottom here, I have an example of prostate cancer. And there's a comparison, in A here, it's a patient receiving protons. In B here, it's IMRT or traditional radiation. And you can see that there's a lot more low-dose radiation that goes to the surrounding structures, in this case, the rectum, the bladder, the femoral heads, for example. And so these are examples where we can mitigate toxicity by using protons. The last indication really for proton therapy is that we kind of across the board ubiquitously use it in patients that have had prior radiation. And again, this gets back to the idea that when we treat tumors, we usually will treat them to tolerance, which means that we will treat them to as high of a dose as we can go, where there's a clinically meaningful benefit. But a lot of that is dictated by the surrounding structures in the area and what they can tolerate. And so often when these tumors unfortunately recur, we'll consider other options, chemotherapy, systemic therapies. But in certain scenarios, patients don't really have any other alternative options, and really need good local control. And so we reconsider reirradiation at that point. But you have to remember that the normal structures have already received essentially maximum dose that they can receive. And so with protons, we're able to really minimize that radiation footprint we leave on a patient when we have to retreat them with a second course of radiation. And so this table basically shows different ways we approach reirradiation. But the major takeaway point here is that protons, as far as ease of use, interval dose, which is basically synonymous with collateral damage, and the conformality are very, very high with protons. And so these are major advantages where protons is more beneficial than other techniques such as IMRT, SBRT, or brachytherapy. Brachytherapy is a very conformal type of technique that also works. It's where we insert isotopes into patients for either permanently or for a temporary period of time and then remove them. And this type of technology can be useful, but you have to remember that we can only do this in select areas of the body. So, for example, endometrial or cervical cancer, we sometimes will use it for esophageal cancer, and we sometimes use it for prostate cancer. But those are really the cancers that this type of brachytherapy is largely limited to, and it's also very much user dependent. So in these scenarios, we really rely on protons, and our Northwestern Proton Center sees a lot of patients throughout the Midwest and really throughout the whole Chicagoland area who are in need of reirradiation. These are additional applications of proton therapy. I'll kind of breeze through this, but the ones that I denoted in blue are really scenarios where we don't really have better options, and in many cases would not even consider doing radiation if we didn't have protons available. These scenarios, again, are adult leptomeningeal disease, reirradiation cases. I had mentioned chordoma chondrosarcoma or uveal melanomas as examples. And then really in the pediatric population, because these in many cases are patients that are very, very young, a couple of years old, all the way up, into, teenage years, for example, we really try to minimize secondary cancer risk and minimize toxicity. And so in many cases, especially when we're talking about brain tumors, we really almost mandate using protons to treat these types of tumors. The rest of these sites here are other tumors that I commonly treat with protons. There is more subjectivity to this. In other words, protons can be of benefit in many scenarios here for other types of tumors. But I also want to point out that traditional radiation or IMRT radiation is just as good, and in some scenarios can actually be better. I'll give you a case example here, but I treat a lot of pancreatic cancer using dose escalation. And I'm going to get to this in a minute, but many pancreatic cancers, they're surrounded by bile, small and large intestines, and there's substantial air, and the bowels are constantly moving. So it creates a scenario where protons are very sensitive to the density of the tissue they're going through. And so if the density is changing on a daily basis, it makes protons a little bit it creates more uncertainty in where they end up. And so in those scenarios, sometimes IMRT-based radiation is actually a better choice. And so for many of these tumors, it's not heavily weighted. Protons is better than photons, but as a few examples, I'll just point out for high-grade gliomas, there was a recent trial that was just published, a phase 2 clinical trial showing that for patients that have GBM, that there was improved overall survival for patients that got proton radiation using dose escalation. For head and neck cancer, there was a recent study out of MD Anderson that showed improved overall survival and less treatment-related toxicity for patients that were treated with oral pharyngeal head and neck cancer. Breast, I'm going to come back to in a minute, but esophageal cancer is another one where we can, for mid-esophagus tumors, we can really minimize heart and overall lung dose. Similarly, for lung cancer, for many multifocal or very large lung cancers, we really heavily rely on those, on using protons in those particular lung cancer patients to really minimize toxicity. And so for each one of these, there are very good examples of where protons can be extremely beneficial. But these are the types, and this is not all inclusive by any means, but these are the types of tumors that we and myself treat typically at the Northwestern Proton Center. So what are the disadvantages of protons? We've talked all about all of the advantages, but really, what are the disadvantages? I think first and foremost is cost and access. Proton therapy is significantly more expensive than conventional photon-based radiation, both in terms of, facility construction as well as treatment delivery. This really limits its availability to select centers. As you could tell, there's, a geographic restriction in the Midwest. There's not a lot of proton centers, this being the only one in the Chicagoland area. And also because it's more expensive, insurance companies typically are inclined to deny it. And so we often will have to go through appeals processes to really prove that protons is better before we can get insurance approval. I will comment that the cost is typically passed on to the insurance carrier rather than the patient. If you compare photon and proton, the deductibles remain the same. So out-of-pocket costs for a patient are really no different. But from a larger, kind of more global view of costs on the overall healthcare system, protons tends to be more expensive. So that's definitely a disadvantage. And then as an extension of that, sometimes because of that, because insurance will initially deny it and has to go through appeals, it can lead to treatment delays. And so that's another potential drawback. And importantly, in cancer treatment, we want to make sure that you get started as soon as possible and we minimize any sort of delays. So this can be another potential disadvantage. And then the last one, which I alluded to in my example of pancreatic cancer in the previous slide, there can be some technical uncertainties that are associated with proton treatment. In other words, protons are much more sensitive to patient setup and organ motion, tissue heterogeneity, and basically what the beam is going through. Another example would be if you're treating a lung tumor. If that particular lung tumor, or that particular lung you're treating now, all of a sudden the patient develops pneumonia and there's fluid in their lung, that will change where that proton beam ends up. And so we have ways to address all of these issues with range uncertainty, and we have checks in place to make sure that we can give very safe treatment. But this is one of the one of the larger challenges with protons is that they're very sensitive to the density of tissue that they're going through. But again, we have very robust treatment planning and frequent replanning that we do to really mitigate these risks. So these are some of the disadvantages. As an illustrative example with the remaining time, I wanted to just talk specifically about one of the indications that I personally am very invested in because I think that this is of great benefit to many women with breast cancer. So for the remainder of the talk, before I kind of field questions, I was going to focus a little bit on breast cancer. The reason I always focus on breast cancer, similar to prostate cancer in men, or analogous to prostate cancer in men, breast cancer is the most common cancer that women face. Roughly 1 in 7 women will develop breast cancer at some point during their lifetime. And radiation really plays an integral role in breast cancer treatment. It used to be the historical standard many years ago was that we would do a mastectomy and we would remove all of the breast tissue. However, over recent decades, we figured out that this was probably over treatment and realized that we could get away with doing a lumpectomy or really removing the tumor, the location of the tumor in the breast, and then following that by radiation treatment. And that was basically in a seminal study shown to be equivalent to doing a mastectomy. And so over the past 25 years, we've, kind of moved more towards doing lumpectomies if possible for early stage breast cancer. But really, as part of that, to really reduce the overall risk of recurrence, we really recommend in all patients that undergo this more minimal surgery, a lumpectomy, that they have radiation treatment after surgery. And so the reason we do this is that there's been or we've shown through meta-analyses that doing radiation leads to a significant reduction in overall mortality 15 years after radiation treatment. So that's really why we do what we do. But whereas about 2/3 of patients have early stage breast cancer, roughly about 1/3 present with more locally advanced breast cancer, and this is when cancer involves the lymph nodes, for example, among other things. And in these scenarios, we have to think about actually giving radiation not only to the breast tissue, but also to all the draining lymph node chains. And the lymphatic drainage for the breast is fairly complex. And so we know that the more medial compartments of the breast, they drain to this internal mammary lymph node chain that is really in the intercostal spaces in between your ribs. They're not really surgically accessible because, again, these lymph nodes are behind the rib cage, so they can't even really be sampled at the time of surgery. The upper inner quadrant can also go to these lymph nodes called the supraclavicular lymph nodes in the neck. And if you have a lymph node that's involved here, it usually is a high predictor of developing subsequent metastatic disease. And so this is a really important chain, and treating this chain is important for minimizing risk of patients going on or women going on to develop metastatic cancer. Lastly, there's in the outer portions of the breast, the axillary lymph nodes that drain the outer portions of the breast. And so when we think about breast cancer, we do sentinel lymph node biopsies at the time of surgery to try to predict where or what lymph nodes are going to drain that part of the breast. But this is somewhat of an imperfect science. And whenever there's one lymph node involved in one chain, we assume that there's a fairly high risk that there can be lymph nodes in the other chains. So we end up giving radiation that not only includes the breast, but really all three of these lymph node chains. And we refer to this as comprehensive breast radiation. And so again, we know that when we do this in patients that have locally advanced breast cancer, when we give comprehensive breast radiation, it reduces the risk of both recurrence and reduces the risk of actually ultimately dying of breast cancer in patients that have node positive disease. So what are the challenges with this? Well, the challenge is that because we have better drugs, there's over 4 million breast cancer survivors in the US today. We have better drugs, better radiation, better treatment overall, better screening, earlier detection, all of these things. And so really the gist of it is less women are dying of breast cancer and they're living longer. And so they're ultimately living because they're living longer, the quality of life or the quality of survival has assumed increasing importance. And so, importantly, cardiac ailments account for the highest number of non-cancer deaths in breast cancer patients. And deaths from cardiac causes actually constitute 10.1% of all deaths within 1 year, and 19% in patients surviving greater than 10 years after a breast cancer diagnosis. This is really no surprise. Cardiovascular disease is one of the primary causes of death in just the general population, let alone breast cancer patients. But it really stresses the importance of really trying to minimize radiation dose to the heart and to the components of the cardiovascular system. Well, when we give radiation using traditional radiation, we usually will use something called opposed tangents. And if you can see my mouse here, we have one beam that's directed this way and another one that's directed this way. And the idea is that there's these two lines or these two beams that come in and they form almost a anti-parallel line here. And the idea is that we want to treat the lymph nodes that I'm circling here, these internal mammary lymph nodes, and we want to treat the axillary lymph nodes here and the entire chest wall. But we want to minimize dose to the heart, which is right here, denoted in this red contour, this burgundy contour, as well as minimize dose to the left anterior descending coronary artery, which is in this little mini red circle here. This is the major blood supply for the left ventricle of the heart. And really, we know that higher doses of radiation to this left anterior descending coronary artery lead to early atherosclerosis and subsequent major cardiac events, such as heart attacks or dying from a heart attack, when we give higher radiation doses. So this coronary artery becomes stenosed when we give more radiation to it. And so the challenge with breast cancer treatment is, how do you treat the entire chest wall as well as the lymph nodes, but minimize dose to the heart and to the internal mammary lymph nodes? We have technologies that we utilize for photon-based radiation, where we'll have women hold their breath, for example, and that puffs out their chest wall and moves the target further away from the heart. We also, in women that have intact breasts, we will sometimes lay them prone, and that pulls the breast tissue away from the chest wall. Again, the idea for both of these scenarios is really we're trying to separate or create more distance between the heart and the actual target we're treating, in this case, the lymph nodes and the chest wall. But sometimes it just doesn't work because of differences in anatomy. And so this is really where protons can be beneficial. But before moving on to that, I wanted to mention that there was a study that was done back in 2013, because we really noticed that when we started looking at women in the 1990s and early 2000s, we noticed that women with left-sided breast cancer had much higher risk of cardiovascular disease than right-sided. And a light bulb went off in somebody's head, basically said, why is that happening? And so there's this landmark study that was published in the New England Journal of Medicine in 2013 that looked at the amount or the rate of major coronary events, such as heart attacks, and the radiation dose that women had received. And you can see that there's almost a linear relationship. There's also no threshold at which there's zero risk. You can see that the second patient gets some radiation dose, that risk of having a major coronary event starts to climb. So there's no minimum dose that's considered safe. Basically, zero is safe. And so you can see here that that as that dose starts to go up, the risk goes up as well. And so from this line, this slope, we know that for every gray of radiation that a woman receives to their heart, there's a 7.4% increase in acute coronary events in women treated for breast cancer. And so this is just another subset analysis of the same paper. But what was interesting is that the rate of acute coronary events went up many, many more fold in women that had underlying heart disease. And so we often will use, and this is based off a very old study, we use certain risk factors for heart disease. These would be type 2 diabetes, high blood pressure, a strong family history of heart disease. I'm forgetting a few here: high blood pressure, hyperlipidemia, or high cholesterol. These are the major risk factors. And so if you have some of these risk factors at baseline, when you receive radiation, that risk is even higher of developing acute coronary events after radiation treatment. And so these graphs basically illustrate that point, that women that are at higher risk at baseline are at even higher risk after radiation. It's compounded by the radiation treatment. And so back to protons. So what's the benefit of using protons? And so these are examples. On the top left, you can see this is conventional radiation treatment or traditional X-rays. And you can see here again, they're trying to treat with a tangent this way. But the issue is that there is substantial heart dose, and you can see how it's bleeding not only into the heart and into the left ventricle, which is the most important part of the heart. It's kind of the powerhouse of the heart, which pumps blood throughout the entirety of the body and also sits more interior is more interior situated. But it also is giving dose to the left anterior descending coronary artery. You can see here with protons, though, that we're able to, again, kind of sculpt dose around the heart and miss the coronary artery right here, so that we can effectively treat these lymph nodes as well as the chest wall and minimize any sort of dose to the heart and to the left anterior descending coronary artery. And this sometimes makes it very difficult when you're using traditional X-rays, because you sometimes have to compromise on missing potential areas that could have tumor so that you can spare the heart, or overdosing the heart so that you can get better coverage. And so in these scenarios, often patients are sent to me for protons because there's not a real great solution. Um, so this again is similar comparisons. These are basically studies that have been done previously and shown that the gist of it is that for patients that have, when we compare photon versus proton plans, the mean heart dose is significantly lower with protons. Um, and so in prior studies of women with locally advanced left-sided breast cancer, protons consistently improved target homogeneity and cardiopulmonary sparing compared to photons, even when they use breath hold or some of these techniques to mitigate that risk. This is just another illustrative example here that we also minimize risk of lung toxicity. So you can see with IMRT here, there's more dose that goes to the interior part of the lung with traditional radiation, whereas with protons, again, we're able to sculpt around it. So we really can minimize the amount of radiation dose that goes to the lungs. And this can, in some cases, translate into less radiation pneumonitis associated with proton radiation over photons. Similarly, in certain scenarios, going back to this example, when we have women that have, for example, a intact breast on the other side, and they have a mastectomy, and we're trying to treat the area that has the mastectomy, we sometimes, as you can see in this example, we're giving radiation to the contralateral breast as well. And so with protons, we're able to really spare the contralateral breast. And this is actually more important in younger women, where when we give radiation dose to the contralateral breast, we can actually increase their risk of developing a secondary cancer in that breast many years later. So one advantage, especially in younger women, not only in terms of cardiac toxicity and minimizing their risk of developing subsequent issues related to their heart, but we can also minimize risk of secondary cancer using protons. And this is a good lead into my next slide, which is basically that, again, protons reduces the secondary cancer risk in women with breast cancer. And so we know this through prior studies that in women that get proton radiation, we give less interval dose, not only to the lung, but to the thyroid, to the contralateral breast, and to other tissues, and thereby it reduces their overall risk of developing a subsequent secondary cancer many years later. These are just comparisons from studies showing the numbers of the average mean dose, comparing different types of photon radiation, which are outlined here on the left, versus protons. And you can see that the lung dose, esophagus dose, contralateral breast, thyroid dose are all substantially lower with proton treatment. So in summary, specific to breast cancer, the benefits of proton therapy is that it can reduce the risk of major adverse cardiovascular events, reduce the risk of radiation pneumonitis and secondary lung cancer, reduce the risk of contralateral breast cancer, and reduce the risk of secondary cancers overall. And so these are really the major reasons why I think, in terms of patients with breast cancer, protons can be very beneficial. Now, with that being said, I'm really particularly interested in a select population of women with breast cancer. For your standard run-of-the-mill patient that has an early stage breast cancer, that has a lumpectomy and needs whole breast radiation, I think for the overwhelming majority of women, you're going to get an excellent plan with IMRT based or IMRT or 3D conformal based radiation treatment, and really protons is not necessary. But for women that have more advanced stage disease, where it's involving lymph nodes, especially the lymph nodes in the chest area that are overlying the heart, those are the women where I think that we can really provide a lot of benefit. And this is just an analysis of the number of women in Illinois that have breast cancer, but this is based off the Department of Health. And roughly about 11,000 women were diagnosed with breast cancer. I think this is probably a couple of years old. But roughly about 11,000 women a year are diagnosed with breast cancer, and we estimate probably about 25% of them have locally advanced breast cancer. And so that really means that there's about 1,372 women that I think that we really can help by delivering proton radiation. And really, again, the goal here, especially in younger women, is to minimize their risk of developing cardiac toxicities, in the years or decades after radiation treatment. So, in summary, that was kind of my illustrative example of some of the benefits of proton treatment. These are kind of key takeaways that I really wanted to emphasize. The unique physical properties of protons can be advantageous by allowing for maximal tumor dose while minimizing exposure to surrounding healthy tissues. And that can reduce the really acute and long-term toxicities by using protons. Proton therapy can reduce treatment toxicity, but importantly, it is not more effective than photons. So if we're talking about killing your cancer, there's no difference between photons and protons. It's a common misconception. Protons are not more effective. What protons can do is minimize toxicity, and in the right patient, this can be very, very beneficial. However, importantly, because there aren't a lot of proton centers, it's important to be somewhat judicious in who you offer protons to, so that kind of in a utilitarian type perspective, you can offer the greatest amount of good to the greatest number of people. So really, I think it's important because this subject is so complicated. I could probably talk for 2 days about this. That it's important that you talk to your doctors, specifically your radiation oncologists, and ask them if they feel that protons could be of any benefit. And if you're uncertain, you can always reach out to the Northwestern Proton Center. We're always happy to see a patient in consultation to discuss this. And last but not least, if there is no benefit of protons, or I really feel like there's very minimal benefit, then I think that getting radiation, using traditional radiation, makes much more sense. And I say this because my last point here is the worst toxicity is really tumor recurrence. I sometimes have patients that are so focused on getting proton treatment, which is totally understandable, but they're so focused on it that they will be denied and denied by their insurance, and then weeks turns to months, and they haven't started radiation treatment, and there's a much higher likelihood at that point that their tumor is ultimately going to recur. So the most important thing is that you get treated, number one. And number two, if you can get protons approved and you really are benefiting from it, then I think that's great. But again, at the end of the day, the most important thing is just getting you treated so we can get rid of your cancer and you can move on in life, and live a happy and productive life after your cancer diagnosis. So with that being said, I'm happy to address any questions that anybody has to the best of my ability here. Thanks for listening. Whoops.
Thank you so much. That was actually very thorough. That some of the pre-submitted questions were already addressed in your talk. So thank you so much for sharing this insightful information with us. A couple of the people who are actually registered do have prostate cancer, and I know you did talk about prostate cancer. Can you you mentioned it a little bit now towards the end of, talk to your doctor if you think it's something you'd want to approach, but can you talk a little bit about where you maybe see it more beneficial in some prostate cancer patients to seek proton therapy?
Yeah, yeah. So there was a recent trial that was recently published comparing protons to photons for prostate cancer called the Particle trial. And it basically randomized men to either photon or proton-based treatment for early stage prostate cancer. We've known, at least through studies, that there is typically some dosimetric benefit or less dose to the surrounding adjacent structures, like to the rectum, to the bladder, with prostate cancer. But we're unclear if this would lead to clinically meaningful toxicity benefits. This Particle trial, which is a phase 3 randomized clinical trial that was a nationally run trial, basically, at least in the initial outcomes that have been published, has really shown that there's not a significant benefit of doing protons over photons. So that's an important point that I always tell my patients. With that being said, though, there are a number of studies looking at patients with more locally advanced prostate cancer. There may be a significant benefit in that case because the radiation field is much larger. And in many of those scenarios, we're talking about either electively or when I say electively, we're treating lymph nodes that are clinically node negative, or the patients have clinically node-positive disease, but we end up treating their pelvic lymph nodes. And in that case, using protons can significantly spare toxicity to small bowel, large bowel, sigmoid colon. So there's a bigger benefit for more advanced stage prostate cancers using protons relative to more early stage prostate cancer.
Thank you for explaining that. For anyone who's maybe treated at a different healthcare system and is not part of the Northwestern treatment system, can they still connect if their doctor determines that proton therapy is going to be a more effective treatment for them?
Yeah. I would say that a large number of our patients are actually outside our system. So we partner with I have many of my patients are their medical oncology team, their surgical oncology team are in the Advocate, Amida, Advent systems, really all the surrounding suburban hospitals. Many of our patients are from U of Chicago, from Loyola, from Rush. Many of them are from Indiana, from Iowa, from Central Illinois, and many are from Wisconsin since there's no proton center. So we partner really with every healthcare system out there. More importantly, or I guess also, we have patients that go as far as like Canada, for example. So we actually have some expertise with dealing with the Canadian healthcare system and treating patients through their system. So yes, we work hand in hand with physicians in other healthcare systems, and that's pretty routine for us here at the Proton Center.
Thank you. Another question that came in through the chat, through the Q&A is, what are some of the typical side effects of proton therapy, and how many sessions does it typically require?
Yeah, so the number of treatments is really determined. It's a fairly complex question to answer. So it really depends on the clinical scenario for both of those questions. So the types of toxicities really depend on the geographic location of what we're treating, and the number of treatments is really dictated by the surrounding structures in that geographic location. So what we do for prostate cancer, and taking a step back, actually, another important point is that each cancer responds differently to the dose per fraction that we use. So certain cancers, like brain cancers, we don't offer shorter courses, whereas something like prostate cancer, we do, and that has to do with the underlying biology of the tumor. So it's really a complex question to answer, but I would say that the side effects with protons are not going to be any significantly worse than they would be with a photon-based plan. And if anything, they may be better or dramatically better. It really just depends.
Thank you. Follow up for the another question is, the person notes not having a radiation oncologist, but only a lung and a neuro-oncologist. If they were interested in getting proton therapy, who would they speak to?
Yeah, so our center has a series of navigators. So they would just have to call our Proton Center, and we have a series of nurse navigators that would kind of help navigate you through that process.
Thank you. This is more of an opinion question. In a perfect world, will there be more proton treatment centers and fewer traditional?
Yeah, that's a great question. From a cost standpoint and really like a healthcare utilization standpoint, I would say there's going to be some limit to the number, but what we're seeing, the general trend is that they are popping up. They're popping up everywhere, and even for places that say that protons isn't needed, it's usually people's opinions change when a proton center appears somewhere. So we're starting to see more that they're popping up in the same city. So like, for example, St. Louis, the two major healthcare systems that are in direct competition, each have a proton center now. Similarly, in Wisconsin, University of Wisconsin and MCW are now both, racing to get a proton center online. So I think that they're going to continue to increase in number, and that actually may, in time, expand and increase their utilization and make it easier for patients in terms of insurance approval, and insurance coverage may expand as they become more and more common.
Thank you so much. This concludes our questions for this evening. Any last thoughts on your end?
No. I guess I would just say talk to your doctors, talk to other people that you know that have cancer. We're always happy to see someone to discuss protons, and honestly, our navigators are very good at knowing who's going to benefit, who's not. And sometimes it's just really a matter of picking up a phone, calling, and if you're really not a good candidate, they're going to tell you immediately. But I think part of the reason I do these is to raise awareness so that people are more aware that this type of technology exists, in hopes that it's more, better utilized going forward. So thanks for everyone's time. I appreciate it. And